Hello, welcome everyone. So today we will be discussing about the electrotherapy and that transcutaneous electrical nerve stimulation that is also spelled by TENS. TENS, it is the electrotherapeutic modality used for the nerve stimulation. Transcutaneous means through the skin. Nerve stimulation is current have sufficient intensity to depolarize sensory, motor, and pain nerves. Application of pulse rectangular wave current. There are types of wave current, that is symmetrical biphasic, asymmetrical biphasic, monophasic waveform. The stimulation parameter of TENS are three types of current. Accurate description in terms of TENS is difficult. They are modified direct current, pulsed current, direct current (DC). Unidirectional current flows continuously in one direction. The AC alternate current is bidirectional current that flows continuously. Pulse current, it is one in which the unidirectional or bidirectional flow of current periodically increases over time. It is more accurate to describe TENS as a pulsed current and not AC or DC. Waveform. Waveform of current simply refers to its shape as seen on a graph of amplitude versus time. Monophasic waveform, current flows in only one direction, one electrode as an anode and other electrode as a cathode. The biphasic waveform, current flows in both directions. Each electrode has a cathode at some part of waveform. In symmetrical waveform, first phase of waveform is mirror image of second waveform, but opposite in direction. Each electrode acts as an active electrode, cathode, during alternate phase. It prevents electrochemical effect due to excessive polarity. Asymmetrical waveform. Two phases which are not equal in size. They have a difference in magnitude as well as in duration. Difference in equality. Slight bias in positive sign. That's why one phase is able to depolarize that act as a monophasic waveform. TENS waveform have zero net DC means equal amount of charges under the positive as well as negative portion of the waveform. It prevents chemical skin irritation. A DC current can potentially cause skin irritation due to buildup of charges under the electrodes. Waveform selection. It can be rectangular, triangular, sine waves, spike waves. The spike waves. The more irritating to skin, require frequent movement of electrode, shorter treatment times to avoid skin irritation, acute pain or resistance tissue, immediate temporary relief for intense or hyper irritating stimulation. Square, rectangular or sine wave. They are longer in duration. For some nerve damage associated with pain pathology, less skin irritation, long lasting effect. And for chronic pain patient. Frequency. It means the number of pulses delivered per second. The time dependent characteristic frequency is equals to 1 upon the period of time. The period is the time elapsed between the specific point on the waveform of the pulse to the identical point on the next pulse. For AC current, time to complete one cycle. For pulse current, for alternate current, for acute cases, we use high frequency. For chronic cases, we use low frequency. Pulse width or duration. Time dependent characteristic in microsecond, and the confusion is there regarding to the pulse duration. Some text either positive or negative. Some text refers both. Most texts refer to duration of only positive component of waveform. It is length of time the current actually act on the patient during each pulse. In normal neuromuscular system, 100 to 150 μ. Neurological damage, wider widths Therefore, 200 to 300 amplitude or intensity. It means a magnitude of current or voltage applied by the unit. It measures that milliampere or volt. Current is due to electron movement. Volt is driving force required for current to pass in the body. So it's level of current required to depolarize the nerve membrane. Ohm's law equals to voltage is equals to Ohm's law is voltage is equals to current into the resistance. A, it can be low amplitude, and B, the brief intense of amplitude. For tens, it is 1 to 100 milliampere, based on the sensation rather than reading, the constant current and the constant voltage. Modulation. There is frequency modulation, pulse width modulation, and amplitude modulation. It causes discomfort. Prevent the accommodation tendency which make the treatment ineffective. Type of tens or modes. There is high frequency or low intensity tens, that is conventional. Low frequency, high intensity tens, that is used for acupuncture tens. Brief intense tens, burst tens, modulated tens. The high frequency, low intensity tens has high frequency that as 40 to 150 hertz, short pulse duration of 50 to 80 seconds. Commonly, gradually increases the intensity, neither pain or nor elicited muscle contraction. The mechanism of action is to stimulate the large low threshold of alpha A beta fibers, causes pain relief via pain gate mechanism at substantia gelatinosa. We will discuss the pain gate theory further on. Decrease the neural activity by affecting the dorsal horn neuron activity. The doses are method for self-treatment. Duration varies 30 to 60 minutes once or twice a day to continue for maximum 8 hours per day to even full 24 hours. Indication of therapeutic uses of high frequency tens, acute soft tissue injury, pain associated with musculoskeletal disorder, post-operative pain, inflammatory condition, myofascial pain. The low frequency or high intensity tens or acupuncture tens. At the low frequency, it lasts up to 1 to 5 hertz. Long pulse duration of 200 microsecond. High intensity up to 330 milliampere or up to patient can tolerate to produce visible muscle contraction. Mechanism action. It simulates the high threshold of alpha, delta, and C fibers. Release of endogenous opiates reduce pain at spinal level. It stimulates pituitary gland, helps to release beta endorphin, blocks the receptor site of A delta and C fibers. It blocks the transmission of pain. Additional muscle contraction gives sensory information through muscle spindle. The electrode placement are for muscle contraction over acupuncture point or motor point of the muscle, the myotome related painful area. The patient will experience paresthesia, twitching type of muscle contraction. Doses 1 per day up to 20 to 30 minutes or at times up to 45 minutes. Acute relief of pain may not be experienced, but relief may be last long. Therapeutic uses of acupuncture tens are long-standing deep aching pain, myofascial pain, or muscle spasm. Next up, brief intense tens. It is high frequency, lasts up to 100 to 150 hertz, long pulse duration 150 to 250 microsecond, highest tolerable intensities, and no longer than 15 at a time. The mechanism action. Pain relief is due to activation of activity in brainstem that dampen or amplify pain impulse. Amplification protocol is referred to as noxious level tens. During the passage through the brain, short circuit occurs, stimulate the release of endogenous opiates in rafting nuclei. Descending pain suppression system activated. Loops afferent impulse down the spinal cord. Opiates inhibit the release of substance P, a neurotransmitter of noxious impulses. The high level analgesia is achieved through this, but transitory. The therapeutic tense, it is local painful condition, painful procedure as skin debridement, suture removal. The burst tense, it provides a packaging of several stimuli in group, presented in bursts of energy sensed by the patient as a single stimulus. It is high in frequency, lasts up to 40 to 150 Hz. It is in high intensity and short pulse. High frequency train of pulses delivered at low frequency. Combination of conventional and acupuncture tense. Mechanism of pain relief by both methods. The modulated tense, pulse length, frequency, and amplitude can be constantly and automatically changed. Provide three of parameters change in cyclic fashion. Prevent adaptation appropriate of conventional tense used for the longer period. The modulated output is more comfortable to the patient. Wave train. Some manufacturers have designed a series of modulation, burst, and standard modes in a pre-programmed flow in a form of wave train. The advantages of TENS. It is non-invasive device, portable, user-friendly, can be used by patient at home, and it is non-addictive. Disadvantages of TENS. It is intolerant to sensation of electricity, skin irritation due to allergic reaction with conductive medium, thermal burn due to chemical reaction on high current density. Intense or prolonged stimulation cause muscle spasm or muscle soreness. Narcotics decrease the effect of TENS. The physiological effects are pain control and the blood circulation. Pain control decrease transmission of noxious impulses to CNS by affecting conductivity of small fibers. Affecting the large motor fibers interfering normal Gaussian pattern of muscle. The blood circulation, cutaneous vasodilatation due to sensory nerve stimulation, axon reflex subsequent release of histamine. The monophasic pulses alter cellular growth and activity improve healing. The indication, chronic pain, acute chronic pain of estrogenic or myogenic neurogenic origin. Post-surgical pain, reduction of post-traumatic acute pain. Application of TENS. The large mains operated, small battery operated or pocket model. Electrode design depends on anatomical location, duration of treatment, clinic or home reactive treatment, sensitivity of patient skin irritation. It is of different sizes and shape. Small electrode or motor points for motor points, for more density. Large electrode for large muscle stimulation. Edge of rectangular or square electrode cause electrical field concentration and current density horsepower. Long rectangular electrode for post-operatively incisional pain. Disposable electrode cut down according to anatomical position. Electrode placement, site of pain over great tenderness, the dermatome and myotome along with the long axis. We will see the electrode placement for the pictures. Trigger point, acupuncture, motor point, etc. Peripheral nerve, long end of the nerve, where it is superficial. Method of electrode placement are direct placement, contagious placement, placement for stimulation point, dermatome placement, myotome placement, spinal root placement, and contrarectal placement. Here are some examples. As you can see, the direct placement. The electrodes over the skin on or around painful site. Each channel runs parallel to each other. Contagious placement. When direct placement is contraindicated, therefore post-operative incision laceration will be there. Electrode near to vicinity of pain. Current will run parallel to each other or cross each other. Stimulation point placement. Motor point, acupuncture point, trigger point. Sensitivity to stimulation in many conditions they are located closely. Single tense electrode stimulates all the points. The trigger point. Sensitive area and muscle or connective tissue that become painful when compressed. Hyper-irritable spot associated with a taut band of skeletal muscle. Compression of trigger point can cause radiating pain, and also it is a point by which pain radiates throughout the muscle and fascia causes myofascial pain syndrome. The dermatome placement, the situation in which pain is distributed according to dermatome wise. Electrode placement is on affected and contralateral side. Other technique involves putting one electrode at the corresponding spinal and nerve root, another at the distal end of the dermatome. The spinal root placement, the placement of electrode parallel to the spine, column between the transfer process, stimulate the spinal root associated with the pain. The contralateral placement of electrode on the opposite side of body, approximately the location from which the pain is arising from the injured side. Theory of bilateral transfer, sensory impulses of one side of the body got confused with noxious impulses of opposite side because of crossing of the nerve tract and spinal cord. The preparation of the patient. The skin below the stimulation should have intact sensory mechanism, works on skin resistance, cleaned with alcohol, soap, water to remove surface lipid, and moisten the skin before application. Comfortable position to not to move or electrode movement. After some, increase the intensity. Preparation of the apparatus. Adjust output parameters, pulse duration, and pulse frequency. Select the electrode, depend on the type of lens. And select the output mode. Depend on the method and duration of the lens. Before starting, intensity should be 0. Increase the output intensity gradually channel wise. Balance the channel, increase the intensity afterwards after some time. The contraindication. Electrode should not put over carotid sinus, anterior aspect of the neck, cause vasovagal reflex and hypertensive reflex, decrease BP. Skin sensation loss, require a great intensity of stimulation, causes skin irritation and burn. Child or adult should not use on the head or neck region of the epileptic patient. Neck of patient of CVA or TIA. Allergic to gel or chemical reaction. The precaution with pacemaker can give an asynchronous type pacemaker, not in synchronous type of pacemaker. It can lead to ventricular arrhythmia. Next up, electrode should be placed as low as possible. Should put away from the heart, lowest intensity of the current given. In case of all lightheadedness or dizziness, turn off the dens. The neurophysiology of pain. The experience of pain results from a physiological response to noxious stimuli. Different factors that influences the frequencies. Cultural differences, state of emotion, and past experiences. Definition. A sensory and emotional experiences associated with actual or potential tissue damage or discharge in terms such as damage. The pain should not be viewed excessively and neither a sensation or an emotion either. Assumption preclude particular characteristic necessary of assume. It should be understood that no rigid pathway for perception of pain, but a multidimensional anatomical and physiological system involved, which takes subjective factor into the consideration. The term nociception is used to describe the specific response to noxious stimuli. The acute pain versus the chronic pain. Acute pain, it is body's response to noxious stimuli. Body's protective mechanism gets activated. Symptoms reflect to underlying pathology. Signs and symptoms of inflammation are very strong and intense pain. In chronic pain, originally pathology is healed. No straight relationship between symptoms and pathology. Chronic pain, there is less inflammation. Subject feel mild pain in certain activities. The pain pathways, the PNS, nociceptor and afferent pathways, spinal cord, dorsal horn, spinothalamic tract, multisynaptic ascending system, brainstem and thalamus, and cerebral cortex. Nociceptors are the sensory receptors responsible for the detection of noxious stimuli, transforming the stimuli into the electrical signals, which are then conducted to the CNS. They are the pre-nerve ending of primary afferent A delta and C fibers, distributed throughout the body, skin, viscera, muscle, joint, and meninges. Can be stimulated by mechanical, thermal, or chemical stimuli. The afferent fibers are first order neuron, second order neuron, third order neurons. Start from the peripheral receptor, dorsal horn, thalamus, and ends at the dorsal horn of spinal cord, thalamus, and sensory cortex. The types of nerve fibers, there are A delta fibers, A beta fibers, C fibers. As you can see, the diameter, myelination, conduction velocity, receptor activation threshold, and sensory on stimulation. Dorsal horn of the spinal cord. A delta and C fiber synapse with secondary afferent neuron in the dorsal horn of the spinal cord. The dorsal horn can be divided histologically into 10 layers called rexed laminae, A delta and C fibers. Transfer information to nociceptive specific neuron in rex lamina 1 and 2. Primary afferent terminals release a number of excitatory neurotransmitters, including glutamate and substance P. These interactions determine activity of the second afferent neuron. The glycine and gamma aminobutyric acid GABA are important neurotransmitters acting at the inhibitory interneurons. In the dorsal horn, the nociceptive afferent makes synapse with second order neuron. The cell bodies of the second order neurons lie in the substantia gelatinosa rolandi of the dorsal horn. The spinothalamic tract. It is a second afferent neuron decussate within a few segments of the level of entry into the spinal cord and ascend in the contralateral spinothalamic tract to nuclei within the thalamus. Lateral spinothalamic tract contains A delta fibers which carries fast, sharp type of pain. Multisynaptic ascending system. This is a diffuse system of many collaterals and relays throughout the brainstem. It carries second order neurons from C fibers which carry slow burning pain. It also ends in thalamus. The brainstem. Reticular formation. It is a diffuse network of neurons which extends from medulla below to the thalamus above. It receives information from the ascending sensory pathway and radiates information to different part of cerebral cortex. It is also have a control over descending motor pathway. The thalamus at this stage, nociception reaches the level of consciousness. The ventrobasal complex of thalamus, which receive neuron from the LST, have the nuclei topographically arranged and send third order neuron to the primary cortex. The second order neuron in MAS terminate in the medial and intralaminar nuclei, which are not topographically arranged and have the third order neuron projecting into cerebral cortex and the basal ganglia and limbic system. The cerebral cortex, finally, the nociception reaches the somatosensory cortex, which is located in the post-central gyrus of parietal lobe. In the somatosensory cortex, the body is represented spatially according to the number of receptors in each body area. This is known as sensory homunculus. As you can see, the pathways of the nerve. The level of pain modulation is peripheral, spinal segment, supraspinal, and cortical. The pain modulation is by pain gate theory, the gate control theory, and the descending pain suppression system. The pain gate theory or gate control theory. This is the theory suggested by Melzack and Wall in 1965. The theory suggests that pain perception is regulated by a gate which may be opened or closed by means of the other input from the peripheral nerves of the CNS. Interneurons present of the substantia gelatinosa cells of the posterior horn of the spinal cord have an inhibitory influence on the T cells. With a large diameter low threshold, mechanoreceptor A beta fibers are stimulated by simple mechanical stimulation of the receptor in the skin, muscle, or joint. The substantia gelatinosa cells are stimulated by an excitatory synapse. The substantia gelatinosa cells receiving input from the nociceptor and the mechanoreceptor integrates and modulates the pain fibers activity and prevent transmission of nociceptive information to higher centers by inhibitory influence on the T cells, resulting in closure of gate of pain transmission. It helps to explain why we bang our hand, it feels better when we rub it. By activating A beta fibers with tactile, non-noxious stimuli, inhibitory interneurons in the dorsal horn are activated, leading to inhibition of pain signal transmitting via C fibers. The descending pain suppression. The descending pain pathways influence on substantia gelatinosa cells by releasing noradrenaline and serotonin. This neurotransmitter produces an excitatory effect on the inhibitory neurons of the SGR in the dorsal horn of the spinal cord and produces reduction of the pain transmission at the level of spinal cord. Descending pathways activate spinal cord interneurons, which release opioids such as ensifalin, which inhibit the T cells, reducing pain transmission at the spinal cord level. The peripheral nervous system. Sensory receptors are a specialized structure that responds to specific stimuli and fulfill the role of transducer. As we already knew, nociceptor are the receptor that responds to the noxious stimuli. The mechanical type or thermal type. As we have seen it earlier in the pain gate theory, the A delta fiber responds to strong mechanical stimulation and damaging heat above the 45 degree, present as a discrete sensitive spots in the skin all over the body surface. The impulses are carried by a small myelinated fiber at speed of 15 meters per second. It provokes immediate flexor withdrawal reflex and evokes rapid, well-localized conscious awareness. The C fiber receptors are sensitive to many stimuli. They're probably sensitive to the chemical release from the tissue damage. The inflammatory changes leading to release of hydrogen ions, histamine, serotonin, acetylcholine, bradykinin, FATP, ADP, and lactic acid. All of the stimulate or sensitize C nociceptor gives dull aching pain. Slow pain is transmitted by unmyelinated C fibers at a speed of 1 meter per second. The free nerve endings are found in all innervated body tissue except the CNS. Yeah, as we can see the afferent fibers, most types of the sensation except that of smell. There are three types: neuron between the periphery and cerebral cortex. The first order neuron, second order, third order. As we have seen, the dorsal horn, cell bodies, A delta and C fibers lie in the dorsal root ganglia and the spinal cord. In dorsal horn, spinal cord, 10 laminae are there. The lamina consist of cell bodies of second order neuron. Incoming A delta and C fiber synapses mainly in lamina 1, 2, 3, and 5. One synapse, they cross opposite side and ascend into the two central pathways. Yeah, the spinal tract, lateral spinothalamic tract, and multisynaptic ascending system. The brainstem structure, reticular formations, periaqueductal gray matter, and nucleus raffimatis. LMS, we have relay station of most type sensation, ventrobasal complex, primary sensory cortex, medial and interlaminar complex, cerebral cortex, basal ganglia, and limbic system. Cerebral cortex, somatosensory cortex located in postcentral gyrus at parietal lobe of cerebral cortex. Perception and interpretation of sensation occurs. Associated cortex relates the sensation to past experience and memory. The dangers and precaution associated with TEDs. Area of skin irritation, damage or lesion. Area with impaired sensation. Over abdominal, lumbosacral or pelvic regions during pregnancy other than labor or delivery. Tissue vulnerable to hemorrhage or hematoma. Extreme caution is needed with patient taking narcotic medication or who are known to have a hyposensitive areas. Incompetent patient may not be able to manage the device. It must be kept out of reach of the children. For patients with diagnosis malignancy that have been diagnosed as a terminal TENS can be used for pain control with informed consent of the patient. Otherwise, TENS should not be used when malignancies are present. Here, the electrode placement. Evidence-based research, there is a considerable variation. One side of stimulation and electrode placement was reported across different studies. The negative electrode should be placed at the distal to the positive electrodes. The negative electrodes may be located at on and around the painful area, or specific dermatome of painful site, or specific myotome of painful area, spinal cord segment, cause of peripheral nerve, over trigger point, acupuncture point of par incision. As you can see, here we can see the dermatomes and myotomes in the body. The electrode placement could be like this for the back pain, for lower back, for upper back, neck. Here you can see for the stiff shoulder, blood circulation, neck pain, leg pain, hip pain, sciatica, the ankle pain, and slip test. This is all it for the TENS.